Hello, good afternoon, ladies and gentlemen. Edwin, please confirm that you can hear me.
Loud and clear, Amos, I can hear you.
All right, thank you very much. Good afternoon, ladies and gentlemen, once again. I have the pleasure to welcome you to this webinar this afternoon, the 25th of August, 2024. And we are privileged to have you around, where we are going to have the talk on the practical approach to classifying and managing adnexal masses. And this afternoon, we are privileged to have Dr. Mubiru. Dr. Mubiru is a consultant gyno-oncologist at the Kawempe National Referral and Referral Hospital, Kampala. He has with vast experience in women's health, and is going to be talking to us this afternoon how they approach the management of adnexal masses. My name is Nwagawa Amos. I am a co-presenter in this webinar, and later on we'll be joined by my colleague, Ms. Navisere Amina, and we will share with you this very important topic. Without much ado, I want to invite Dr. Mubiru, who will start for us the session. Dr. Mubiru, you're welcome.
Thank you, Amos, for this introduction. Good afternoon, all present. I'm called Dr. Mubiru. I am a gynecologist working with Kawempe National Referral Hospital here in Uganda. And I'm glad to be here to present our practice, how we approach patient adnexal mass as both as gynecologists, as gynecologists in Kawempe, and also to highlight a few things we really want to look at when we ask for investigations from our friends, the radiographers. Thank you, Amos. We can start the slide sharing.
Yeah, can you confirm you can see the slides?
Yes.
Yes, we can.
So basically, managing a female patient adnexal mass is challenging to both the gynecologist and the gyno-oncologist. And usually management of these masses will depend on whether it's benign or malignant. As the benign approach, if it is a benign mass, the approach may be a little bit different from malignant approach, where benign may consider conservative, managing conservatively, or even fertility-sparing surgery, or whether but malignant, if you want to do surgery, the surgical approach is a little different from the one of benign. It's more radical. It also depends on the patient's age, of course, as you know. The diseases, sometimes the malignant or the conditions are different according to the fertility cycle of a woman. So usually the perimenopausal women, their masses tend to be more benign as compared to the postmenopausal women. Postmenopausal women, their masses tend to be a little bit malignant. So, and second, also you have to put in a view. Usually these premenopausal women may like having children. Second, also you don't want to cause surgical menopause. So management still will depend on the person's age. Then also, I said, future party desires, someone wants to have children, you may go slow or removing their ovaries. Then someone having a family history of malignancy, if a patient has a history of malignancy in their family, you may think we are dealing with a malignant process, which is starting early. So you take that patient, you have to have an extra eye or an extra look when you're dealing with that patient, as compared to a patient who has not had any history of malignancy in their family. Majorly the obstetric, the ovarian, breast malignancy, or endometrial malignancy, and colorectal cancer. You really have to take them with caution when you see them, when they see they have an adnexal mass. Next slide, please. So the patients with malignant tumors should be managed. They are better managed by the oncologist. This has been proven scientifically that patients who had malignant tumors or malignant adnexal masses had a better survival, a 9-fold better survival when they were managed by an oncologist as compared to the general gynecologist. That's why we always prefer these patients to be referred to the gynecologist. So if someone has to really find out, someone has to take time to find out whether this mass is dealing with is malignant. If he suspects it's malignant, it's better to refer that mass. So they should be evaluated, as I said. And this is through obtaining clear history, examination with this pelvic assessment. You do tumor markers and radiological investigations, as we shall look at. But these parameters alone separately are inadequate to what? They are inadequately sensitive or specific. So they are bundled together. You consider them as a unit to really identify whether this patient is having a malignant process or she's having a benign process. Next slide. So when you ask for investigation, usually ultrasound scan, it has been proven that the transvaginal ultrasound scan it's better to assess pelvic mass. So it's better to use a transvaginal ultrasound scan when you're assessing an adnexal mass, and because it can bring out the characteristics of the tumor better than the abdominal ultrasound scan. And so we prefer, when we send these matters to our radiographers, to really consider using a transvaginal ultrasound scan. And then we can say the tumor markers also can be used to identify whether the mass is benign or malignant. And also we can use the morphological characteristics of the transvaginal ultrasound scan. And these morphological characteristics include, if a mass is, for example, unilateral or septated with a septa of less than 2 millimeters, studies have found out and this is more of it's more of a benign lesion. But if just the septa is more than 3 millimeters, you may think you're dealing with a benign tumor or a malignant tumor, but it can still be benign tumor. If you have a complex mass on scan and has cystic and solid areas, this mass is highly malignant. So you can increase the index of malignancy, and you think of referring this patient to what? To a gynecologist, a gynecologist. Secondly, if there's increased blood flow, and the presence of ascites, these can make you start thinking that I'm dealing with a malignant process. And if you're general gyne, you can start thinking that I should refer this patient to a gynecologist. So the tumor markers also which help us also determine, like the C125 alpha fetoprotein. C125 can help you to know whether you're dealing with serous an epithelial tumor. Alpha fetoproteins to look at yolk sac tumor, which is cell tumor, TCG, to think about it, non-gestational choriocarcinoma. Inhibin A and B you can think of a cell tumor, sex tumor. And LDH can make you think about the scheminomas. So these can help us predict malignant potential. And in a premenopausal woman, if the C125 is elevated, we usually say the cutoff is 200 because it's non-specific. So it has a sensitivity and specificity of 50, sensitivity of 70% and specificity of 26 to 92%. And you can see the wide range of positive predictive value in a premenopausal woman. But in a postmenopausal woman, having an elevated C125, you can see the predict positive predictive value ranging between 73 to 100%. So that's why you can see the different cutoffs. In a postmenopausal woman, we can say cutoff of 35, in a premenopausal man, we can look at cutoff of 200 because of the sensitivity of C125. The similar other causes which other things can lead to increase in C125, like pregnancy, PID, endometriosis in a premenopausal woman. Next slide, please. So having all these sonographic findings and biomarkers, they cannot independently predict malignancy. So we've come out with different, scientists have come out with different indices where they combine all these biomarkers, professional and patient profile to predict the risk of malignancy. And you have heard about it, risk of malignancy index, risk of ovarian malignancy algorithms, and the Adnexal, IOTA Adnexal model. All these are developed to try to increase to increase the predictivity or increase the chances of us predicting that we are dealing with a malignant process. And as such, we want to manage this patient in the right way or correct way. And my colleague is going to talk about these indices. So now like just like this patient, we are seeing how do we approach this patient. It comes to us, it has been referred to us with by general gynecologist to oncologist to try to manage this patient. So we first have, when you're approaching this mother with an adnexal mass, putting putting all factors into consideration: the age, fertility desires, the menopause, the status of the menopausal status. So putting all this into consideration, we take the detailed history of a patient and we examine this patient. Detailed history to find out does this patient have any risk of malignancy from history. When we examine, are there features of malignancy in this tumor? Are there features of metastasis? And then you also try to examine this patient. Can you ably resect this mass? Then you also go ahead and do investigations. So where you can do the tumor markers, the imaging as you have put it out, you do ultrasound scan, you do CT, can do a CT abdomen, and if you must, you can also do a PET CT if now you are thinking that you are dealing with a malignant process and trying to look out for metastasis. Then you go ahead and do risk classification. And then, of course, all these things are just increasing the predictivity or increasing the chances of you thinking that you're dealing with malignancy. So for you to get a diagnosis, another thing we do is if they have a site in Uganda, in Africa, we shall take off the acidic fluid for analysis and ask for histology. For them to tell us if there are malignant cells in this ascites or not. We can also try to do an ultrasound biopsy to see, to pick a tissue and try to take it for histology to tell us if you're dealing with malignancy or not. And some centers have laparoscopy. So in these centers, we shall go ahead and do a diagnostic laparoscopy. It helps us both get a diagnosis, get a biopsy, and also to stage, helps us to look for any metastasis around the abdomen. But if you don't have a diagnostic laparoscopy and you are afraid to do this other minimum invasive procedure, you can go ahead and do a min laparotomy. It's our last option where you do about a 5 to 10 centimeter, a 10 to 15 centimeter incision, and you try to look at pick a biopsy of this mass. It can also help you try to feel around the abdomen and try to stage this tumor. And after you've confirmed that you're dealing with a malignant process, you go ahead and do a staging laparotomy. Next slide, please. Hello, Amos, you can move. So by and large, we are saying a transvaginal ultrasound scan is recommended for imaging modality pelvic mass, and NSS which is greater than 10 centimeters with papillary projection or solid components or regularly or these ascites, you think of a malignant process. If you combine this with C125, and so you can combine this C125 and also patient's age and menopausal status for you to increase the chance of thinking that you are dealing with a malignant process. So there's room for minimum invasive procedures. Usually, if you're told you think the adnexal mass is benign, cystic, irregular, young woman, may do minimally invasive, and also there's room also for fertility preservation when managing patients, adolescent women and young girls. You can think of doing fertility preservation. And then in pregnancy, it shouldn't be so hard. It shouldn't hurry. Most of these masses we see in pregnancy have a low risk of malignancy or acute complications. Sometimes we manage them conservatively. We just do expected management. Thank you. I think that's the last slide. Thank you for listening. These are our references. Thank you for listening. We can entertain any questions.
Dr. Mbiru, do you want the questions now or do you want the questions after all the presentations? We have a few hands up. I'm going to pick a few hands and then we can proceed. Yes, Amina, your hand is up.
I think someone else can go first. Thank you so much, Edwin, and thanks, Dr. Mbiru, for the presentation.
Hello, my colleague and friend Celestine. I'm going to unmute your mic, then you can go ahead. If you unmute on your side, Celestine, you should be able to ask your question.
Okay, thank you so much, Mr. Mills. And thank you, Doctor, for the wonderful presentation. My question is this. I wanted to find out of how much of use is a transvaginal probe when you have a huge pelvic mass, even though you suspect, it could be malignant. Of what use? How relevant could that be? A transvaginal scan for a huge pelvic mass.
Okay. Thank you, Celestine. I think the question is how relevant is transvaginal scan in cases where you have a huge pelvic mass? Amos, are you going to be touching on this topic or do you want Dr. Mbiru to answer this question before you start your presentation? Amos, I can't hear you. I think you're on mute.
Sorry about that. I want to request Dr. Mbiru, with your permission, Edwin, that we first go through the second presentation and then we can answer colleague Celestine's question.
Oh,
Thank
okay.
you. Yeah.
Thank you. So some of these will be detailed in the follow-up presentations, and we might be able to pick some answers. So I suggest if you have any questions, type them in the chat like we've always done. Type them in the chat, and then after we'll pick out these and present them to the presenters for a detailed response. But thank you. Keep the questions coming. Thanks, Celestine. So do we go to the next presentation, Amos?
Yeah, thank you very much. I want to take the pleasure to welcome colleague Amina. There were some technical glitches and she could not join us on time, but I am glad that you are now on board. Yeah, and Amina, do you have any comments to make before we proceed?
Yeah, since I'm late and people are already on, I think we can just go on. We'll just answer the questions later. Thank you.
All right, thank you very much. My name once again is Nuagawa Amos. I am a specialist sonographer, and Dr. Mbiru has given us the clinical perspective. And in this segment of the presentation, we are going to look at the practical approach to classifying and managing adnexal masses using the IOTA criteria. For status IOTA is International Ovarian Tumor Analysis. This was work of a group of researchers who gave us the predictive models in 2000, and for about 14 years now, IOTA criteria has been integrated in many national guidelines, and they use it as the mainstay of classifying and managing adnexal masses. And the classification is mainly to be able to tell us whether a mass that is seen on ultrasound is benign or malignant. And so our outline, we will first go through the IOTA terms and definitions. These are important so that when we talk or speak or write, we understand each other. Not only as sonographers, but for the people who use the work that we do, the gynecologists, and across board of the multidisciplinary team who are usually involved in the managing and classification of adnexal masses. So the second part will be IOTA two-step strategy, where the first step is benign descriptors, and then step 2, ADNEX model. We have some cases. These are cases that we came across during the study that we did at Kawempe National Referral Hospital, and I want to urge the audience to be attentive, because along the way we will have a number of poll questions. We will also have the opportunity to share with you key findings of our study on IOTA prediction models at Kawempe National Referral Hospital, and at the end, the audience will have the opportunity to ask questions, and then we will answer them. So this is one of the papers which was given to us by the IOTA group in 2000, and it gives us the terms and definitions and measurements, and how we can apply this information in the classification of the adnexal masses. So first, IOTA terms and definitions. Let me pick my pointer here. Just a second. All right. So papilla is solid tissue projecting into the cavity from a cyst wall with a height of greater or equal to 3 millimeters. Dr. Mobilu has already alluded to this echogenic material which could be projecting into the cyst cavity. And for a papilla, we are saying that it should have a height of greater or equal to 3 millimeters. So if you have any echogenic material projecting into the cavity that is less than 3 millimeters, that is not a papilla. Those are just described as irregularities, and we commonly see these in hydrosalpinx. So we usually measure the papilla from the inner margins of the cyst wall, and we usually do not include the cyst wall or septum. So you can have a lesion that has papilla, and you can have a lesion that has no papilla. And it is important to note that presence of papilla increases the risk of malignancy. So septations are thin sheet of tissue across a cyst cavity from one internal surface to the other, and we should see it across the entire length of the lesion. So if you have incomplete septum like this, these are not septations, and we simply call them irregularities, as we have already seen. So a septated lesion likely to be malignant. So the absence or presence of septi gives rise to what we call the multilocular or unilocular cyst. Multilocular if you have more than one septi, and unilocular if you only have one cavity. Again, if you have incomplete septi, we don't regard this as a multilocular cyst. This is just the same cavity, and it is just that the lesion that you're seeing could be folded against itself, like in hydrosalpinx, and they usually represent the mucosal folds. Multilocular likely to be malignant, and unilocular unlikely to be malignant, and we usually think if you have a unilocal lesion, that is probably benign. Acoustic shadowing, this is another important artifact in the classification of adnexal masses, and acoustic shadows means absence of echoes behind a sound absorbing lesion. So presence of acoustic shadowing, according to IOTA, increases chances of malignancy, and we commonly see acoustic shadowing in the clinical practice quite commonly in dermoid cysts, fibromas, and you can also see the acoustic shadowing in cystadenocarcinoma fibromas. For wall, we usually also want to see the regularity of the lesion, and for solid lesions, we usually look at the outer walls, and for cysts, we look at the inner walls, and therefore for solid lesions, you can have a lesion that has irregular margins, irregular wall here, but you can also have a lesion that has regular outline. For cysts, as I said, we look at the internal wall, so you can have a lesion that has regular walls, but you can also have a lesion that has irregular walls because of presence of papilla. Regular wall likely to be benign, and irregular lesion increases chances of malignancy. For contents of the lesion, you can have a lesion that is anechoic, which means absence of any echoes. You can have a lesion that has low level echoes. You can have a lesion that has ground glass echogenicity or hemorrhagic and mixed. But you can also have a lesion, a solid lesion that has hyperechoic echogenicity or hypoechoic echogenicity. What we should note here is that the echogenicity of the lesion is not very important in telling us whether a mass could be benign or malignant, but they are very useful according to IOTA in categorizing the masses into various histopathologies. Now, here, if, for example, you have a lesion that has ground glass appearance, you will all know this because this is quite common. You will think that this is probably an endometrioma. On the other hand, if you have a lesion that has mixed echogenicity in a unilocular cyst, you want to think probably this is a hemorrhagic cyst. For ascites, ascites is any fluid outside the pouch of Douglas. A little bit of fluid in the pouch of Douglas is not ascites, and according to IOTA, we only say there's ascites if there's any fluid above the uterine funnels. For morphological classification that Dr. Mobilu alluded to, it is very important that when you see a lesion, you look out for these features where we have a unilocular tumor with probability of malignancy of just 1.3. You can also have a multilocular tumor where you have multiple septi, but without solid component, and the probability of malignancy there is just 10%. You can also have a unilocular solid tumor where you have some papilla, and that increases the malignancy to 37%. And you can also have a lesion that is, we describe according to IOTA as multilocular solid, where you have multiple septi and presence of a solid component. This raises the probability of malignancy to 43%, and where you have 100% solid tissue, or this on solid tumors, we look at either 80%, over 80%, or 100% tissue. So this means that if you have a little bit of cystic tissue here, but by subjective assessment, over 80%, 80 or over 80% is solid, we still classify this lesion as solid. And that increases the risk of malignancy to up to 65%. And this was according to Timmerman and others in the year 2000. When it comes to color flow, we have color score 1 to 4, where color score 1 means no flow, color score 2, mild flow, color score 3, moderate flow, and color score 4 is abundant flow. And the presence of color flow, meaning vascularity at Doppler, increases probability of malignancy. When it comes to measurements, we usually take 3 measurements, where we take an image in the sagittal plane and take another image perpendicular to the first image, and then we take the length of the lesion, take the height, and then we go to the axial image and take the width of the lesion. If we are interested in the weight, in the volume, we multiply what we get by 0.52, but many machines have the presets, and so they can obtain the volume for us. And according to IOTA, we sometimes are interested in the maximum diameter of the lesion, whereby we go around the lesion, even when in the sagittal plane or in the axial plane, that is not where you get the maximum diameter. We go around the lesion and obtain the maximum diameter of the lesion. So having seen the IOTA standard terms and definitions, we now go to how we classify the lesions. And according to the current standard, we use the 2-step strategy. And I must say that IOTA has been improving over the years since they introduced the IOTA term, IOTA models. And the current practice is that we use the 2-step strategy, whereby the first step is simple rules using benign descriptors. We are going to see to which masses do we apply the benign descriptors. And if there's any lesion that does not satisfy the criteria for classification using benign descriptors, that is goes to step 2, which is ADNEX model. And this is a paper that validated the performance of the ADNEX model and the IOTA 2-step strategy, and it's a very important paper that would be interesting to look at. There were other risk stratification models. Dr. Muru told us about the risk of malignancy index. There's also risk of malignancy algorithm, logistic regression 1 and 2, but it is important to know that through a number of validation studies, the IOTA 2-step strategy outperformed all these other models. And in many settings, especially in high-income countries, this has become the mainstay of classifying and managing adnexal masses. For lower and middle-income countries, it's a conversation, and when we will be sharing with you our research findings, we'll talk about where we lie as low and middle-income countries. So first, the step 1, benign descriptors. And what is interesting is that some masses have typical features and therefore very easy to classify by way of pattern recognition, and we reflect on the clinical practice, more of the experts. But I will also say that what is interesting about IOTA models is that it was established that even in the hands of a non-ultrasound expert, they still perform very well. In one of the validation studies, it was established that they perform as good as expert subjective assessment. But of course, the challenge with expert subjective assessment is that the experts are not always available, especially in the low and middle income setting, in low resource settings. And so this is why IOTA becomes, a very important prediction model. And so we can actually classify 35 to 70% of the adnexal masses, depending on the population you're studying. If you're studying, let's say, a premenopausal population, the percentage of the masses that you can classify using benign descriptors could be higher. However, if you are studying a population that is largely postmenopausal, probably would classify less. And so we have 4 benign descriptors. It is important to note that all are unilocular. but benign descriptor 1 is a unilocular tumor with ground glass echogenicity and largest diameter less than 10 centimeters in a premenopausal woman. And if you do histology, the specific histopathology could be an endometrioma. Benign descriptor 2 is a unilocular tumor with mixed echogenicity, acoustic shadows, and largest diameter less than 10 centimeters in a premenopausal woman. And this is quite, they usually say the eye knows what it knows. This is very familiar. And if we do histology, the specific histopathology diagnosis could be a dermoid. Benign descriptor 3 is a unilocular anechoic tumor with regular walls and largest diameter less than 10 centimeters, and the specific histology could be a sister adenoma. The benign descriptor 4 is all remaining unilocular tumors with regular walls and largest diameter less than 10 centimeters. So this is data from a validation study of IOTA phases 1 and 2, which involved over 3,000 masses, and benign descriptors would apply to over 1,000 of them. And here we have the benign descriptors. Certainly, they predicted outcome benign, and then this is what was predicted. And then when they did histology, this is how the prediction matched against the specific histology. So they really perform very well. You simply look at a lesion and you're able to decide whether you can apply a benign descriptor and which specific one of the four. So if there are any lesions that cannot be classified using benign descriptors, and then we go to the second step, which is IOTA ADNEX model. And here is one of the papers that offered practical guidance for applying the ADNEX model from IOTA group to discriminate between the different subtypes of adnexal tumors. So what is ADNEX? For beginners, ADNEX is assessment of different neoplasias in the adnexia, and we have 9 features. 3 of them are clinical: age, the center where the ultrasound scan was done, and CA125. Those are the clinical features. 6 of the features are ultrasound features. These are features you obtain on ultrasound, and it was established that if the scan was done at an oncology center compared to if it was done at any other center that is not specialized in oncology, it was established that it would offer more accurate risk stratification. And CA125 helps in differentiating stage 1 to stage 4 cancers versus metastatic disease and stage 1 versus stage 2 to 4 cancers. What this means is that with ADNEX, it not only classifies, distinguishes between benign or malignant, but if you've done CA125, it will give you the possibility that the cancer is under any of these categories. So it can predict for you if the cancer you're seeing, yes, it is cancer, but in which stage could it be? So that's the beauty about this predictive model. So these other features are on ultrasound, where we are interested in the maximum diameter of the lesion, maximum diameter of the largest solid component, and then you ask yourself whether they are less or more than 10 cystic locules, and then you count the number of populations where we want to know whether it is none, 1, 2, or 3, or more than 3, and then you feed into the model. The model asks you whether the lesion you've seen on ultrasound has acoustic shadows or not, and you simply have to say yes or no. And then for ascites, we also ask ourselves whether there's ascites or no, and you simply want to say yes or no. It is important to know that this is a low-cost ultrasound variable. I mean, these are low-cost ultrasound variables without the use of Doppler. According to IOTA, this was done on purpose so that even in a low-resource setting where somebody is using a basic ultrasound machine, you should be able to do the calculation using ADNEX model. Yeah, because as we will see, you can have it on the phone or on a laptop, and you simply need to get these ultrasound variables and then feed them into the model. So this is what we need to obtain on ultrasound: maximum diameter of the lesion, maximum diameter of the solid component, if it is there. If it is not, you leave it out, you put in 0. By subjective assessment, we ask ourselves, how many locules do we have? Are they more than 10 or less than 10? More than 10 for a yes, less than 10 for a no. And then we look at the internal outline of the lesion, and then we ask ourselves, how many papillary projections do we have? Is it 1, 2, 3, or more than 3? And then for acoustic shadows, you look at the lesion and be able to answer whether they are acoustic shadows or not. And then for ascites, as we said, ascites is any fluid above the fundus, and then you answer yes or no. Somebody asked about TVS and transabdominal, and this is what Dr. Muru told us, that IOTA actually is based on transvaginal ultrasound. However, in clinical practice, it is, you may not argue that whether TVS, yes, TVS is preferred, but in some cases, especially if the lesion is much bigger and is not only confined in the pelvis, you might really find a transabdominal probe very useful, and it is also very useful in cases where you have ascites. If there's ascites, and if you just use a transvaginal ultrasound, you not assess all the potential spaces of the peritoneum. And so we are saying we prefer transvaginal ultrasound, but it is, both the TVS and transabdominal complement each other for us to be able to obtain very important information. So this is the ADNEX model interface. As I said, age of the patient in years. So if you have a patient where you want to apply ADNEX, you put the age of the patient here, and then oncology center. If it was done at an oncology center, you tick yes. If it was done at any other center, it is no. Maximum diameter of the lesion in millimeters, maximum diameter of the largest solid component in millimeters, and then the cyst locules. This is for 0 to 10, and then if they are greater than 10, you tick there. You tick one box depending on what you have. Number of papillary projections, where we have none, 1, 2, 3, and more than 3, and then acoustic shadows present or absent. Ascites, you simply tick what you have, and then if you've done serum 125, you put the figure here, and then the model will calculate for us here. Probability of benign ovarian tumor, it will give you the percentage, risk of malignant ovarian tumor percentage there, and so on. So IOTA, the ADNEX model was initially available online, but according to European legislation, it was deemed to be a medical device, and that required a CE mark, and it was taken down because of that. But before it was taken down, it was available online, and you could have it on a smartphone, and it has been integrated in some ultrasound machines. There's actually the application that is, I think, on Evidencio. This is the application that we used in our study, and if somebody could actually access it on Evidencio, but even when you get it, it might not be the updated one, but I'm sure once it undergoes certification, it should be able to be available again on the IOTA group website. So the other investigations, as Dr. Mobiru said, for imaging CT, you could do a PET CT, especially for if you want to stage the lesion, MRI, and then these are the different tumor markers that can be done to be able to get as much accurate risk stratification as possible. So we will now go share with you some of the cases from our study. And case one is of a 55-year-old female, postmenopausal, HIV positive on ARVs, and she came with lower abdominal pain for over 1 year. These are the ultrasound images, multilocular lesion with maximum diameter of about 8, and it had a solid component which was measuring about 2 millimeters. So when you have a lesion like this, for you to apply IOTA models, usually, as we said, the first step is benign descriptors, and you ask yourself, you ask yourself whether you can apply benign descriptors. Remember, we said with benign descriptors or unilocular, this is multilocular, and this means that we cannot apply benign descriptors. And then we go to step 2, which is ADNEX model, and then these are the parameters. We feed them into the model, and according to the model, and the model, if you have CA125, as I said, it will give you the subgroups in case it is malignant. Now, according for this specific tumor, according to ADNEX, it had 98.3% probability of being a benign ovarian tumor. This patient underwent surgery. That's the lesion after laparotomy, and the specific histopathology was of a mucinous cyst adenoma, which is benign, as had been predicted by ADNEX model. Case number 2 is of a 60-year-old female, para4+0, postmenopausal with abdominal swelling and lower abdominal pain for 7 months. On ultrasound, multilocular tumor, no solid component. So if we say multilocular, that means we cannot apply benign descriptors, and we go to ADNEX model. We fed in the model here, and according to ADNEX, the probability of benign tumor was 96.3%. And then you can see risk of malignant tumor 3.7, and then the different subcategories of the malignancy. Borderline 2, stage 1, 0.4, stage 2 to 4, 0.8, and for metastatic disease, 0.5. So according to ADNEX, this was deemed to be a benign tumor. The patient underwent surgery, and the specific histology was ovarian cyst adenoma, which was consistent with what had been predicted by ADNEX model. So, so with prediction, you can actually use the prediction with or without CA125. As I said, if you use CA125, then you'll get the prediction, for the different subcategories of the malignancy. I had loved to feed into the model with one with CA125 and then the other with CA125. Unfortunately, because the model the application we used, we think it is outdated because of the European legislation that I talked about, and the model could actually not give us a prediction if we did not feed in the CA125. But for colleagues who have the equipment that has ADNEX model integrated in their machines, you could actually feed in these values and let us know what it gives us. So case number 3 is of a 37-year-old female, para4+1, premenopausal state. She had lower abdominal pain and persistent bloating for over 8 months. And when we did the ultrasound, we found a multilocular tumor with a solid component. And then again, we asked ourselves, could we apply benign descriptors? The answer is no, because this is a multilocular tumor. And then we went to ADNEX model, fed into the model, the clinical parameters and the ultrasound features, and probability of benign ovarian tumor was just 1%, and risk of malignant ovarian tumor was 99, risk of borderline tumor 27.2, stage 1 cancer 3.9, stage 2, stage 4 63.4, and stage metastatic disease 4.3. And for if you have a model, the application that is up to date, it should be able to give you even the relative risk, and you can outrightly see where the risk lies. So according to ADNEX, this was a lesion that had high malignancy potential. Patient underwent surgery, and the histopathology was ovarian serous adenocarcinoma, which is a cancer as had been predicted by ADNEX model. Case number 4 is of a 22-year-old nalpalus woman in premenopausal, and she had had the recurrence of lower abdominal pain and swelling following cystectomy the previous year, and the recurrence was a bit of suspicious. And for this specific patient, because of this recurrence, even before anything else could be done, Dr. Mubiru actually requested that this patient's slide is looked at again, which again implied that it was benign, but because of reoccurrence, he decided that this patient undergoes laparotomy again, and so that the histology could be done again. So again, we ask ourselves, can we apply benign descriptors? This is a multilocular tumor, and benign descriptors may not apply because of that. And so we went to ADNEX model. According to ADNEX model, the probability of benign ovarian tumor was 95.8%. Surgery, and it again confirmed that this was a serous cystadenoma, which was benign and was persistent with what ADNEX model had predicted. Case 5 is of a 65-year-old female, para 9+0, postmenopausal state, and she was a known diabetic with low abdominal pain for 5 months. And I want to ask Edwin if we could run a poll question here, and we would like to know if how many people think we can apply benign descriptors to this specific adnexiomas. Edwin, could we please run the poll?
I have launched the poll, and it should have popped up on your screens. If at all it did not, please check your chat, and it will be within the thread in the chat. Click the options. We have yes, no, and I don't know. And then we'll tell you the poll results. Thank you.
All right. So Edwin, we could give it maybe 3 or 4 minutes.
That's true. Let's give it about 3 or 4 minutes.
All right. Thank you. Should anyone think I should take them to the slide for benign descriptors? Please let me know.
I think that would be a good idea. So,
so
let us all critically look at the slide for benign descriptors and then come back to this lesion.
Yeah, you let us know when you can give us the poll results, Edwin.
Yeah, so far 85% of the participants think that yes, we can use benign descriptors for this one, and 14% say no. Let's give it one more minute and then I'll tell you the results.
Okay.
Submit your results, and then
Okay.
Amos will go on.
Yeah.
So 87% say yes, 12% say no. None of them doesn't know. So at least we have participants who are sure of their answers.
All right. Thank you very much, Edwin. Let's first flashback here. Benign descriptor 1, unilocular tumor with ground glass echogenicity and largest diameter less than 10 centimeters in a premenopausal woman. I want to think all agree with me that the image we have here actually has a relation with the benign descriptor 1, isn't it? Okay, so that is for according to IOTA, benign descriptor 1, a neuroocular tumor with ground glass echogenicity and largest diameter less than 10 centimeters in a premenopausal woman. We'll go to our image, ultrasound image. If we look at the diameter, maximum diameter was 8, which is consistent with the benign descriptor 1. However, this was in a postmenopausal woman, and that automatically means we cannot apply the benign descriptor, and so the 12% actually have it. So it is very important that you critically look at what you have, because if it is a postmenopausal woman, this could be a malignant tumor, and you classify it as a benign tumor, and when you catch it late, and the goal of diagnosis and prediction is to catch it early in case it is malignant. Because if you look at the 5-year survival rate for stage 2 to stage 4 cancers, Dr. Mubili will tell you that it's really, really poor compared to when the lesion, malignant lesion, is diagnosed when it is still in stage 1. So the audience, dear audience, we cannot apply benign descriptor to this particular lesion because this was a lesion in a 64-year-old postmenopausal woman. Thank you. I thank you so much for participating in the poll. Please be attentive because there's another poll that is coming. So we could not apply benign descriptor to this lesion, and we went to ADNEX model, and according to ADNEX model, the probability of malignancy was 98.3%. Members, you note that even when the benign descriptor cannot apply, and ADNEX model will tell you whether this is probably a malignant tumor or not a malignant tumor. And according to ADNEX, probability of benign ovarian tumor was at 98.3%. This patient underwent surgery, and the histology confirmed that this was an endometrioma. And for pattern recognition, because you are experts in ultrasound, this is what people commonly call the chocolate cyst. And according to ADNEX, because you look at the walls, it was regular, no ascites, and this is why the prediction was for benign at 98.3%. Case 6 is of a 71-year-old female, postmenopausal. She had presented with progressive abdominal pain and bloating. ultrasound, a multilocular lesion with a solid component. Multilocular meaning we cannot apply benign descriptors. We went to ADNEX model. According to ADNEX, it had the risk of malignancy at 98.8%. Patient underwent surgery, and this confirmed that it was a low-grade serous carcinoma of the ovaries. Case 7, the last case, is of a 22-year-old nalpalus woman, premenopausal, had lower abdominal pain and PVDCI for 8 months, and the ultrasound scan, which was done on the 1st of July, we saw a unilocular cyst. And then the question is, can we apply which benign descriptor applies? Yes, because this is unilocular, premenopausal. This means that we can apply benign descriptor, but which one? Which of these? Edwin, could you please run another poll? We would like to know which benign descriptor can apply to this specific adnexal mass.
I've just launched the poll. Please do the same as we did for poll 1. BD is a benign descriptor, so there's BD1, BD2, BD3, and BD4. Click on whichever benign descriptor you think. Yeah.
ED, same, you can take it to be same as BD.
Keep the responses coming, please.
Yeah.
So far, we have 5 responses, and all the 5 think it is benign descriptor 2.
Benign descriptor 2.
Let's see if we can have maybe 5 more to make it 10. We now have 6 responses. All of them are thinking it's benign descriptor 2. Let's give it 1 more minute.
Okay.
Celestine, what do you think? Donald, what do you think? Eva, Farouk Osman, Fungai Zimbende, what do you think? So far, we have 10 responses. Of the 10, 8 think it's BD2, and 2 think it's BD4.
2 think it's BD4. All right, thank you. So we will just review maybe, with the options that are in the answers. BD2, BD4. BD2 says unilocular tumor with mixed echogenicity, acoustic shadows, and largest diameter less than 10 centimeters. So it means in the lesion, we'll be looking out for shadowing. Yes, mixed echogenicity, I can see. I must say, for this specific patient, actually declined TVS, and the different, because you can see here benign descriptor, we have a TV obtained by TVS, and for this patient, it was by way of transabdominal. However, if we check critically, mixed echogenicity, yes, I can see. Yes, and you can actually think persons who responded that it's benign descriptor 2, yes. However, if you look critically, we don't seem to have acoustic shadows. And yeah, it's a debate, but I like the idea that the concept is there. Some people are beginning to sharpen the eye, but we think the one which applies is benign descriptor 4. And for this specific patient, because the risk of malignancy was low, she was managed expectantly, and the scan that was done on the 25th of July showed that the ovary was completely normal and the lesion had dissolved, and we thought this was just a retracted clot in hemorrhagic cyst, and there was no reason for alarm. And so there have been a number of papers that have evaluated the clinical utilization of ADNEX model. This is one of them, but trust me, there are so many, and it has been found to be really be a very good model for predicting the potential for malignancy versus benign tumors. And in many settings, it has been integrated with ORADS. ORADS is a commonly used pattern recognition means of classifying adnexal masses, especially in America. In Europe, ORADS, ADNEX model and IOTA are the mainstay of classifying masses. And there was a consensus paper by the American College of Radiologists who integrated it with ORADS, and in this paper they evaluated if they integrate it with they integrate ADNEX and ORADS and see how to manage the patients. So this is an important slide, and Dr. Mobilu and others will know that this is what is used for making clinical decisions. On the left, where we have step 1, is where we have high benign potential, and for normal ovaries, that corresponds to ORADS 1, and then classic benign lesions, that corresponds to ORADS 2, and in these first two, in most cases, that patient is managed expectantly. Conservatively, these are the categories where you need to preserve the fertility potential and so on, and because the potential for malignancy is very low. And then here, if a lesion does not fit here in step 1, where you apply benign descriptors, that goes to step 2, where you have the cutoffs for malignancy that help you in how best you can manage the patient. This is it has to do with what decision are you going to make, and where is that patient going to be managed? Is it at a local gynae clinic, or is going to be sent to a specialized clinic where they can access gynecology? So if the risk of malignancy is less than 1%, that corresponds to ORADS 2, and you're almost certainly sure that that lesion is benign. If the risk of malignancy, according to ADNEX, is less than 10, is between 10 to 1%, that corresponds to ORAD 3, low risk, and that patient can be managed in a local gynecology clinic by means of surgery. If the risk of malignancy by ADNEX model is between 10 to 50%, that corresponds with ORADS 4, and that patient carries intermediate risk, and patient could still be managed at a local gynecology clinic. But if you send to a specialized gynecology clinic, that would improve the patient outcomes. And if the risk of the malignancy is over 50%, corresponds with ORADS 5, and that is equivalent to high risk of malignancy. And it is very important that patient is sent to a gyn-oncology clinic where other imaging workups and tumor markers can be done. And so we will share with you our key findings in the study on IOTA models. This is a study that we did at Kawempe National Referral Hospital, and we established that ADNEX model is a fair model in discriminating between benign and malignant masses, and the area under the curve was 0.6. Of course, you will remember that in many validation studies which have been done, especially in high-income countries and a few selected low and middle-income countries, the performance of ADNEX model was confirmed to be much higher. However, of course, we noted that for us, we did it on a relatively small proportion number of patients. Our sample size was 22, and probably we thought that's the reason why the sensitivity and specificity of ADNEX model was was a little lower. However, it was still, promising. We thought it was really a promising model, and if in future another wider validation study is done, we should be able to reach that good performance as was established in other settings. We also had another sub-study where we were assessing the acceptability levels of TVS by female patients at Kawempe National Referral Hospital. And as we said, this was important because we were doing what we call a feasibility study, and it was important that we also assess the study interventions. As we said, TVS is the mainstay of IOTA, and we wanted to know how many women, the perceptions of women towards vaginal ultrasound, and we established that 80% of the women out of the 206 responded that they could allow to undergo transvaginal ultrasound. And we also established that the factors that were significantly associated with the acceptability of TVS were practice of dosing and awareness of TVS. What this means is that if there was a woman who was practicing dosing and had been told about TVS, they were more likely to accept the intervention compared to women who are not practicing dosing and who had never heard about TVS. We also had another study, another sub-study, where we were assessing the acceptability of ADNEX models. However, of course, because there was very low level of awareness, we later modified our objective to establishing awareness. First, we wanted to know the acceptability, but if people were not aware about the intervention, it was hard to assess acceptability, and we modified it to awareness of IOTA ADNEX model, where we established that over 90% of the health workers at Kawempe National Referral Hospital were actually not aware of ADNEX, and just a small proportion of just 10% are the ones who were aware or had heard about ADNEX model. So in conclusion, IOTA ADNEX model, which is a mathematical prediction model, has high sensitivity and specificity of about 0.8 and 0.79. However, of course, this was from a study that was not done in low resource settings, and it is comparable with expert subjective assessment. However, the experts are not always available, and this means it becomes very important, especially for our low resource settings, where even a non-expert can still classify adnexal masses with significant accuracy. And ADNEX has excellent discriminatory ability of distinguishing between benign and malignant tumors. which is as high as 0.94, and this was according to Timmerman. And in our own setting from our study at Kawempe National Referral Hospital, we demonstrated that IOTA model is a promising screening tool with fair discriminatory ability of 0.6. And we thought there is a need for a wider validation study for IOTA models in Uganda, because for any intervention, much as it is validated in other settings, if you are going to incorporate it into clinical practice, it is very, very important that it undergoes validation so that every stakeholder is confident, and you can lobby the policymakers to integrate it into the clinical practice. And the study was a bit, complex, but we had a wonderful team, and we want to thank especially our research supervisor, Dr. Sam Ali, was very, very instrumental in making sure that we successfully undertake that study. We, of course, cannot miss to thank our lead surgeon, and I am glad that you spared time to share with us this webinar, and we share our experience and the approach to adnexal masses. So we want to thank you, Dr. Mobilu Musa, for the wonderful job you are doing at Kawempe and for making our study a success. We thank Professor Marcus. Professor Marcus is an academic giant. He was very, very instrumental in fine-tuning our protocol, and even during implementation, he was very, very resourceful. We are trying to do a multi-center study, and we have a colleague, I am not sure whether he was able to join in this webinar, Dr. Samuel, and Professor Marcus was very useful in making sure that we undertake a multi-center study, and the journey for validation of IOTA models in especially our setting, I know is a journey that is beginning, and so we thank Professor Marcus for the support he's giving us. We thank Ernest Cook University. Initially, I know this is transiting from the Research Institute, Professor Kawe and the entire team at ECRI. We thank you very much. We cannot forget to thank Uganda Cancer Institute, Dr. Jackson Rem, the Executive Director at UCI, Dr. Nixon Nyonzima, he's the head of research and training, and Dr. Riga and the entire team, the histopathologist. UCI gave us a waiver for carrying out CA125, and of course, the entire team at Kawempe National Referral Hospital, ED, and the wonderful people in the gynecology clinic. And of course, we cannot forget ITEC. ITEC is a research organization. They are undertaking a wonderful research at Kawempe National Referral Hospital and in many centers across the country, as well as at international level. ITEC gave us the logistics, the equipment, and all the logistics that we needed to carry out the study. I thank you, and of course, we cannot forget our colleagues in the MDU cohort 2019 and all the people that made this possible. Thank you very much. These are the references for people who may want to read here and there to be able to gain more perspective on ADNEX model. I thank you very much, and now we will go into the discussion where you can ask more questions and if there are any issues that we need to clarify. Thank you very much. Over to you, Edwin and Amina.
Thank you so much, Amos. That was a wonderful presentation, and I think I speak for all the people who participated and attended. It was quite enlightening and educative. Thank you so much, Dr. Mbiru, as well. It has been quite resourceful, and it is always nice to hear from both sides, both the diagnostic side and the management side. Without wasting any time, I will let Amina take over, and then she can welcome any questions from the audience.
Okay, thank you so much, Adrian, and Dr. Muiro, and my colleague Amos. If there are any questions from the audience, you can either raise your hand or text in the chat, type in the chat so you can take up the questions. Thank you. So maybe as we're waiting for people to ask questions, I remember there was a question which was raised earlier after Dr. Mbiro about a transvaginal catering for huge masses. Yeah, I know my colleague Amos has talked about that, but also to clarify more, as we're doing the research, actually even in the IOTA protocol, it's very well stipulated. We very much want to have the endovaginal scans, but there are those very huge masses whereby if you do like an endovaginal scan, we are not able to do it to finish all the masses. We see part of the masses. So we always resort to the transabdominal ultrasound such that we can have a full view of the mass.
Yeah.
Yeah. Any questions? So I believe either the members well understood this so well that there are no questions.
It was well presented and very
It was well
palatable.
presented, yeah.
Yeah.
But we also request members, as Amos stated, we did this research in Kawempe and we're looking at doing a very wider study in different countries. It will really be good. We have gotten one person who is interested, and he's in which country is that, Amos?
Malawi.
It's in Malawi. So we request members, if you're out there, you could be, because I know usually we have like a big following from maybe West Africa or what, because the challenge is that this IOTA ADNEX model has been, many studies have been done, but not in our setting in Africa. There are very few studies. So we're calling out on members in different countries. If you're interested, I know we usually have a very big team from Zambia, Zimbabwe, South Africa, Eswatini. So if you think this is really very beneficial, you feel free to always contact us through either Ultrasound Africa, or you can always email us, me and Amos, because we're looking at a very big, like multi-centered study. That will really be very good. Thank you. So we're having Martha. Okay, someone is asking for the ultrasound WhatsApp group. Edwin will help us share that. And then Martha, thank you very much for the wonderful presentation. Just want to confirm whether this is recognized worldwide already, because Doctor, you continually said it's our research, we found out. Yeah. Okay, Amos, Martha is wondering whether this is already recognized. I can also answer this, or Amos will also add on. Martha, this is a study we did at our master's level, and we are looking so much forward into publishing this. We haven't yet published our study, and this is part of maybe part of our research dissemination. We're still going on. As you looked at the numbers, since it requires surgeries, we don't really get so many cases. So we have already had 22. We're looking at least we look at a minimum of 30 cases. Maybe that after we'll proudly publish this. Amos, you have anything to say about this?
Yeah, yeah, thank you. I mean, I think that's it. Yeah, that's the thing. We will need to see a number of other participants, and then in the future we make a publication about this, God willing, and of course undertake a wider validation study. So and then we can, because it is very concerning if we look at a very useful model as it is, and it is only in books. It is only in books, and we need to rally behind everyone, all the policymakers, for the wonderful people in the academia to undertake research and make sure that we we facilitate the transition from research into practice.
Okay, thank you.
Yeah,
Amos
thank you.
Wycliffe is saying thank you for the presentation and is asking what are some of the limitations for the ADNEX model. Still, I'll go for that, then Amos will chip in. As Amos reported earlier, in this study we had a subsection where we are actually assessing acceptability of the ADNEX model to these people. We had a challenge that, okay, we know that ADNEX is more of a transvaginal, and according to our population, not very many people are familiar with the transvaginal scan. So you find that one of the challenges we had, some people decline to transvaginal ultrasound. Though the good news is that according to our statistics, majority of the women would really accept. We just had a few cases whereby women would decline to the endovaginal ultrasound scans. And then two, also after, like, because like it's not relevant for us to do like a scan and we don't end up like having a proper management for a patient. We find that we had so many patients whereby after like maybe scheduling them for surgery, some ran away and they didn't want to be managed, or they didn't never wanted to have the surgeries done, and then they had to go to like maybe herbalists and other people like for management, and then later on they would come when it was really very late. And given that we didn't have like someone funding and we're using like Kawempe National Referral Hospital, actually this is where we take a point in time to thank Dr. Mbiru, who like welcomed and appreciated like our study. So you find that with Kawempe, it's a national referral hospital, and there are very many cases, very many people are waiting for surgery. So you can imagine if someone's scheduled for surgery and then they end up like running away that particular day they're supposed to do. So it disorganizes everything. So those are some of the key challenges we faced when we're doing this particular study. Maybe Amos could also add on that.
Yeah, it's fine. It's you have elaborated it. It's okay.
Okay, then Abby is saying, I wish to convey many thanks to the presenters for the wonderful work done. I just request that you share the presentation to us for further reading and understanding. Okay, Abby, I think that will be done. Then
Yeah.
CEO Doctor is thanks for the elaborate presentation, but I would like to get these slides such that I get these references for our next model. Yeah, definitely we'll share the presentation either on our website or on our Ultrasound Africa WhatsApp group. Thank you so much. That's Shamim Bakashara. Thanks very much, our presenters and organizers of this presentation. My addition to the TVS is that there is detailed lesion viewing and most of the images texture is well seen. Yes, this is very true. Yeah, I believe because as the sonographers, because I know it's a team of very many people, but we believe that if you try to compare an image for the TVS and then a transabdominal, the TVS comes out better. The only limitation which we faced, or which actually IOTA like catered for, is that if the mass is too huge, sometimes you don't have the whole view when we're using a TVS. So we'll do a TVS, then we'll still go ahead and have a transabdominal scan. So then thank you for this presentation. Amos, you have something to say?
It's
Yeah,
Edwin.
maybe did we answer Martha's question? She was asking, is this already recognized internationally? Was that the question?
Yes.
Yeah.
Yes,
Did
we
answer
did.
that?
Yes,
Okay.
we did.
All right.
Make some clarification on that response, because I have a feeling she's of the view that whatever was presented, including the ADNEX model, the IOTA, are all a result of the research that was done at Kawempe. So you might need to make a clarification.
Okay.
Okay, Amos, you take up, or I can.
Yeah.
Amos, go ahead.
Martha, thank you very much for your question. And we want to say it is actually in our setting where we are not applying ADNEX. If you look at Europe, in many other settings, they're actually using IOTA. IOTA's two-step strategy, benign descriptors, and if there are any masses, because we said we can classify up to about 70% of the masses, and then the remaining 30% are either classified using expert subjective assessment or ADNEX. So it is already recognized, and I am sure after this talk, Martha and the many others are going to be interested in looking at some literature. It is so abundant, and many countries have integrated it in their national guidelines, and it's what they are using. So it is not that we got the intrigue to talk about IOTA out of our research. It is that we are actually not using IOTA, and we hope that once we do the validation in our settings, then we can also undertake to use ADNEX model for classifying the adnexal masses. Thank you.
Yeah, thank you, Amos. And so there's another question. Thank you for this presentation. Apparently followed patients to surgery, considering malignant masses and seeding. Was the surgery done after chemotherapy? Dr. Mburu is on. I think he's going to give us more. He's going to answer this question. Dr. Mburu?
Hello.
Yes, we
Hello.
can hear you.
Okay, thank you. Thank you very much. Surgery, as you asked a question, was it done after or before? But what we used to do, what we do when you are going to take the patient to theater, or what we used to do was to try to assess resectability of the mass and tumor. And our major goal is to make sure we come out with no R0, where you have you resect all the tumor masses. So what we do usually, we assess this patient. If we think we shall be able to remove all the visible cancer cells or malignant cells.
Dr. Mburu, are you there? Dr. Mburu, are you able to hear us?
Sorry, it seemed to have lost Dr. Mburu.
I think we have lost him. Yeah, but as he was saying earlier, we would really like, it was a team, because definitely we'll do the ultrasound, but Dr. Mburu, as was introduced earlier, he's a gynecologist. So he's so much well versed with these masses. Actually, just because we didn't present everything, but there are those cases whereby they would say that maybe we're not going in for surgery. We could maybe do like, they could also be like, we had like maybe aesthetic tap and then do like maybe aesthetic fluid analysis and see, or like ultrasound guided biopsy without laparotomy. So we had those cases just because we have usually like little time, but I believe in the publication, once we have it done, we'll be able to share each and everything. Yeah, thank you, sir. And Donald was saying patients prefer we use endocavitary pelvic ultrasound instead of transvaginal scan when writing their reports. Did you get similar suggestions from your group? Otherwise, great work. Wish to we adopt to it locally and harmonize practice and minimize misdiagnosis. Surprisingly, we didn't get people, because actually most of the ladies we saw, it was their first time hearing about transvaginal ultrasound scan. So we didn't get any. Maybe Amos, if there's anyone you came across, but as throughout the study, I didn't get anyone suggesting to call it endocavitary pelvic ultrasounds.
Yeah, I think that's yeah, it's an important point that Donald is making, and just like in when we see missed abortion and many want to say, we say miscarriage. I think it's better. Yeah, I think it's important. Maybe in future we can see how to harmonize that, and we write what is more acceptable in the community. Thank you.
Yeah, so Shamim is telling us, okay, Zimbidi, inside presentation, many thanks. Yeah, Bakshara is saying IOTA and ADNEX model are well recognized worldwide. Yes, Shamim, it is recognized, but it gives us a reason, because some things can be recognized out there, but in our setting, that's why we need to do a lot of research in our settings. Because you find, like, for example, when we're starting, like, for the breast reporting system, the BIRADS, you find that it took people like a lot of time for us to integrate to the BIRADS recording system. And why I want us, or we advise so much for us to do these studies, is that, like, you look at the, like, the clinicians who are supposed to send us, like, maybe these patients for the transvaginal scans, you find that many of the clinicians didn't know about IOTA ADNEX model. So when we do research and we validate these studies in our settings, and think it will really be very helpful to our community. Thank you.
Yeah, Doctor. I see Dr. Sam Ali online. I'm
Oh,
wondering
it's
if
nice to
you
have him.
will have a word or two to throw in there.
Yeah, and Mr. Dr. Sam Ali can unmute. Maybe members, I would like to introduce to you Dr. Sam Ali. He was our research supervisor, and without him, I think we wouldn't have done this research. So he could have a word or two to say about this particular study. Dr. Sam, you're welcome.
Yeah, okay. Been given my mic was mute before. Yes, good afternoon. Is it already evening or afternoon? So some people evening means at 4. But thank you so much, Amos, Amina, and Dr. Muviru for this very wonderful presentation. I know I came in a bit late. I had some other engagements, but I tried to make time to at least listen in for the last minutes. And I think wonderfully presented. And the message is very, very clear. You can see the value of this research. Of course, I must say that the scope of the current research, just to make it clear to people, is it wasn't basically a validation study per se, I should say, but testing the feasibility of implementing such a complex study in our setting. And I must say that the team here has been have done their best to ensure that they deliver the best quality. I think you can just see from the quality of the slides and images in the slides. So basing on what we learned from this study, of course, like they've already highlighted, this ADNEX model is already being implemented into many guidelines, including ISWOG actually. So they really recommend the use of this. And initially there was an app, a mobile app for use of this model, but incidentally, I think there's been a lot of FDA regulations on medical applications and or medical apps, and I think that's been pulled down a bit due to some regulatory issues. But I must say that it's highly recommendable for use, and we do anticipate that we could plan maybe the next phase where we look at a large validation study, learning lessons from the current study. So there are some groups with interest in this. I think one is already on board from Malawi, and he's also a gynecologist. And you will be able to implement this on almost a similar number, maybe 40 women. So if we have slightly many centers coming up, then I think it's possible to integrate the different sample sizes from the different centers, and it can be somewhat like allow for analysis of the diagnostic accuracy of this test if you have a larger sample. That's why I can say that this may not be exactly validation because the sample is really very small, but was a part of feasibility assessment, but well executed. I cannot thank Dr. Mubiri enough for supporting the team, because this is a project that required more of a multidisciplinary approach to ensure that it is delivered on successfully. Of course, Uganda Cancer Institute for supporting to undertake the CA antigen cancer antigen tests CA 125. But what I should also emphasize is that this is a very simple tool that, in the absence of CA 125, you can still achieve equally similar performance or diagnostic performance. So to me, it feels like this is one of the tools that could have greater impact if implemented. The main idea behind this is to try to think about screening in centers where people cannot access very high level facilities, because most times women are referred for screening at a tertiary care level, or like maybe at Uganda Cancer Institute right now, maybe to Mulago. But is there a way we can do the screening at maybe the lowest level so that we can reduce the number of unnecessary referrals? So this is how helpful this thing can be, to be able to minimize the cost and also the trauma that can result with this, because you can be able to save out a few who you can refer, and then refer those that are highly suspicious for better screening at a tertiary care level. So this is how, for personal, I envisage this tool could be very useful. And the beauty is that, what makes it very, very useful is that you just need a black and white ultrasound scan to, even in the absence of CA125. I think this is, to me, was very amazing. It was one of the easiest tools that can be integrated into LMIC settings. So that's what I can say for now. But I want to thank the team so much for doing this very wonderful and very complex work, and we are happy to continue supporting to ensure that we bring some of these tools that can improve outcomes in our setting. Thank you.
Thank you so much, Dr. Ali, for those remarks. I don't see any other questions. Back to you, Edwin.
Thanks, Amina. Thanks, Samali and Amos and Dr. Mbiru. It was quite wonderful, and it was nice to have this talk. I now call the webinar to close. Thank you.